Our lab today is about rectum and anal canal. I will start with the rectum. Although the rectum as a meaning is called citrate, but actually it is folded. The rectum is folded on the sides with one fold on the left and two folds on the right. And also the rectum is folded anterior-posteriorly. At that sample, I can see the anterior-posterior folding. The anterior-posterior folding, the above one, the superior one, shows a concavity anteriorly, and it follows the concavity of the sacrum and coccyx. That is the sacral concavity of the rectum, which is upper part of the rectum. And here is a perineal concavity that is convex anteriorly, not concave anteriorly as the sacral concavity. The rectum begins at the level of S3 vertebra, and before S3, this is the sigmoid colon. And the rectum ends here at the anorectal flexure. You can see this angle where the rectum is directed backward to be continued at this region with the anal canal at the anorectal junction. That is located about a few centimeters, one and something centimeter in front of the tip of the coccyx. The anterior surface of the rectum is covered by peritoneum. This is the peritoneum covering the anterior surface of the rectum in its upper two-thirds. And you can see that the lower one-third of the rectum, this one, is not covered anteriorly by peritoneum, because here, after the second third of the rectum, the peritoneum is reflected, as is shown in this sample, to the urinary bladder. This is, of course, a male sample, forming the rectovesical pouch of peritoneum. The lower one-third of the rectum is called the ampulla of the rectum. That is the widest part of the rectum. This ampulla, when it is filled with feces, you feel the desire to defecate. Okay? And therefore, it is not normally containing feces. It must be, when the feces is in the ampulla, you must empty it. You will feel the desire and you will go to empty it. And this lower third of the rectum, which is the ampulla, the widest part of the rectum, is separated from the urinary bladder by the rectovesical fascia of Dinovillaire, that is shown here by the green color, and also is connected or attached with the concavity of the sacrum by the fascia of Waldeyer. This is the fascia of Waldeyer, connecting the sacrum with the back of the rectum. Well, this is the rectovesical fascia of Dinovillaire. Therefore, the rectum posteriorly is related to the sacrum, related to the coccyx, and related to this, which is sacroanal ligament. This is the anosacral ligament. And if you, in addition to these posterior relations, the sacrum, coccyx, and anacoccygeal ligament, the back of the rectum is also related to, as you can see here, to piriformis muscle, coccygeus, and levator. Here, this is the position of the rectum. So it is related to coccyx, sacrum, and coccygeal ligament as bones and ligament. Muscles, which are piriformis, coccygeus, and levator. And also it is related to sacral nerve, sympathetic chain, of the pelvis related to median sacral artery, lateral sacral arteries, and superior rectal artery. While, going back to this sample, anteriorly, the rectum, we had just described the posterior lesion, anteriorly, the upper two-thirds of the rectum that is covered anteriorly by peritoneum is related anteriorly to the rectovesical pouch. And therefore, it is related to the small intestine, to the sigmoid in this region, in the pouch. And more anteriorly, it is related to the urinary duct, seminal vesicles, prostate, ampulla, vase, ureter. All of these are located anteriorly. Prostate and other structures on the back of the urinary duct. This is all about the rectum in regard to its curvatures and what is regard to its relation. The inside of the rectum, the mucosa of the rectum, shows a longitudinal fold that is a transient fold, because these longitudinal folds will be disappear if the rectum is filled with feces. But in addition to these transient longitudinal folds, the mucosa shows transverse folds. These transverse folds are permanent. They are called valves of Houston. Why they are called valve of Houston? Because they are functioning to separate the gaseous from fecal material during defecation. That's why you may able to pass platters without feces, because the valve of Houston controls that. Right? I will talk something about the rectum as just what I had just described in female sample, plastic, and also on the cadaver now. So let us bring that samples away. This is a female, and that is the rectum. This is the valve of Houston. This is the upper two-thirds of the rectum anteriorly covered by peritoneum. Here the peritoneum is reflected to the uterus. Actually, it is reflected to the posterior fornix of vagina and then to the uterus, forming recto-uterine pouch of Douglas, mimicking rectovesical pouch in male. And the lower one-third of the rectum, which is the ampulla of rectum, is separated from the vagina by this fibrous tissue, and this is the fascia of Waldeyer. The white color is the fascia of Waldeyer, connecting the back of the rectum with the sacrum. So it's the same. And even the lateral relation is the same. What remains is the cadaveric sample. Just look to the sacrum. This is S1. This is lumbar vertebra. This is S1, S2, S3. So this is the rectum. Below my forceps is a rectum, and above it, this is a sigmoid colon. And the rectum follows the concavity of the sacrum and coccyx, and then shows a convexity forward, which is perineal convexity. And you can see that the upper two-thirds of the rectum is covered by peritoneum, but here the lower one-third of the rectum is separated from the seminal vesicles. This is the ampulla, this is the seminal vesicles, this is the ureter on the back of the bladder, which is the base of the bladder, by a fibrous tissue that here is separated, which is rectovesical fascia of Dina. And if I take a fibrous tissue between the back of rectum and sacrum, for example this one, this is the fascia of Waldeyer, okay, connecting the sacrum to the rectum. And what is remaining is that I will open the rectum looking for the transverse fold, which is this one of mucosa, that is the valve of Houston. This is the valve of Holstein. Of course, valve of Holstein are three. Two are always present, one, the lower one, or the lowest one is sometimes absent. So just look to the urinary bladder, prostate, and this is the rectum. And in consideration to posterior relation, I will remove the rectum. See that this is piriformis. These are the sacral nerves. And this is levator ani and coccygeus. This is coccygeus and that is levator ani and that is piriformis. All of them are related to the back of the rectum. In addition to the sacral nerves, vessels and nerves will be studied in the next lab on Sunday and Tuesday. Right? So now we will pass to the anal canal. And I will turn back to the male sample. You know, previously, female was the first, the male was the first. So, this is the anal canal. This is the anal. It starts at the, sorry, this is the anal canal. It starts at the anorectal junction that is connected by the anococcygeal ligament. This is the anococcygeal ligament. And it ends at the anus. The anal canal, which is this one, shows three parts. The upper part, which shows these longitudinal folds, which are called anal columns. These longitudinal folds of the mucosa are connected below with each other by transverse folds that are called anal valves of Morgani. And this line of anal valve, which are transverse folds connecting the lower ends of the longitudinal anal column fold, this line of anal valves is called pectinate line. This line is very important embryologically because the anal canal above this line, the pectinate line, is derived from the endoderm, while the anal canal below this line is derived from the ectoderm. And why is this important? Because sometimes you have فطر بالعربي, fissure in ano. Fissure in ano, فطر بالجلد, may involve the lower part below the pectinate line. And because this part is derived from ectoderm, its nerve supply is spinal. So it is very painful. This fissure is very painful. But the fissure if it is above the pectinate line, the line of anal valve, it will be in the endodermal part of the anal canal. And this part is supplied by autonomic nerve, sympathetic, and it will not be painful. It will be really slight pain. Therefore, you must not pectinate line. So the upper part of the anal canal, above the pectinate line, showing the anal column, is endodermal. Below it, this is the first part, of course. Below it, you have a transitional zone and subcutaneous zone. So you have three parts in the anal canal. And the space above the valve, these are columns, longitudinal folds, connected at the lower end by transverse folds, valves of Morgani. The space above the transverse fold, where I'm putting my tip of forceps, is called anal sinus. Right? This is what regards to the inside of the anal canal, that is showing the fold of longitudinal columns and transverse valves of Morgani and pectinate, that divides the anal canal into three parts. Let us go outside the mucosa. Outside the mucosa, you will find a transverse or circular muscle, which are this one. This is an internal anal sphincter, which is a smooth muscle. It is autonomically supplied and involuntary controlled. But you can see that the circular internal anal sphincter do not or does not extend to the entire anal canal. the circular muscles of the internal anal sphincter surrounds only the upper two-thirds of the anal canal. You can see that the lower one-third of the anal canal is not surrounded by the internal anal sphincter. Here, this is fat, right? So the upper two-thirds of the anal canal, after a mucosa, you have certain mucosa histologically, but anatomically we have circular internal anal sphincter. And to outside of the internal anal sphincter, this is the external anal sphincter, which is divided by description into a deep, superficial, and subcutaneous part. The external anal sphincter is divided into three parts. What I want to add that between the internal anal sphincter and external anal sphincter, this line is called the conjoined longitudinal coat. It is a coat of the smooth muscle seen here and there between the internal anal sphincter and external anal sphincter. Why this conjoined longitudinal coat is important, which is a smooth muscle coat between the internal anal sphincter and external anal sphincter? Because this coat divides here into many septa attached to the skin. But the most lateral septum is this one. It's called perianal membrane. This is the perianal membrane. Don't forget, this is the anococcygeal ligament at the anorectal junction. Anococcygeal ligament from the coccyx to the anus. But this is the perianal membrane. It is dividing laterally from the conjoined longitudinal coat between the internal anal sphincter and external anal sphincter. What is the importance of this perianal ligament or membrane? This perianal ligament divides the fat here into two regions, as you can see. The fat above it is fat in the ischiorectal fossa, while the fat below it is the fat in the perianal space. This is perianal membrane, a branch from the septa of conjoined tendon. And below it, this is the perianal space, while above it, this is ischiorectal fossa. And so what? Why this is important? Because the fat, as I said in the last lab, in the perianal space here, the fats are surrounded by complete septa, forming balls or loculi. And these balls or loculi of fat in the perianal space sometimes get infected from infection of hair follicle, and these balls will be filled with pus due to infection of the hair follicle, and there will be pus in a ball that will produce tension on the wall, and it will be perianal abscess. This abscess is collected in the ball of the perianal fat below the perianal membrane. This perianal abscess will be very painful, and the patient will not be able to stand. You have to open it and evacuate it. Okay? If recurrent infection in the perianal region, there will be an opening there, which is called perianal sinus, that continuously will discharge pus to outside. But if the patient will not take care about this, the infection will ascend up to the fat in the ischiorectal fossa. Unfortunately, the fat in the ischiorectal fossa is not completely surrounded by the fibrous loculi. Therefore, the infection will spread in this fat without pain. And the patient will have recurrent attacks of pus to outside, as the infection will be recurrent, and then it will be open to the mucosa of the rectum, to forming here an opening in the rectum, an opening to outside, and that is the fistula, perianal fistula. It's not so. Right? By PR examination, you may feel two constrictions, two circular rings in the anal canal. One of them is this, which is located at the anococcygeal, anorectal junction. This is it, which is called anorectal ring. That is produced by the deep external anal sphincter and puborectalis part of levator area. This is it, anorectal ring. But here we have another groove, which is between the subcutaneous and superficial parts of the anal canal, which is called the white line of Hilton. This white line of Hilton located at the lower end of the internal anal sphincter. وهذا internal anal sphincter. It ends there. So this is the white line of Hilton. Below this spectinate line, then you have white line. Spectinate line and white line. Let us imagine that this is the white line. Okay? So you have a pectinate line, a white line that divides the anal canal into three parts: subcutaneous, superficial, and deep part. Of course, above the pectinate line is derived from the endoderm. More to outside, the anal canal is related anteriorly to the perineal body and bulb of penis in male, while posteriorly it is related to the tip of coccyx. In female, this is the anal canal. It is related anteriorly to the perineal body and vagina, and posteriorly also to the coccygeal ligament. This is the coccygeal ligament, and this is the perianal membrane. The same talk could be described for the cadaveric sample, but unfortunately in our cadaveric sample, the subcutaneous and superficial part of the anal canal is artificially removed. You can see that you have only the upper part of the anal canal that shows longitudinal folds, which are called anal column. You don't have anal valves, you don't have pectinate line, because all of the anal canal below the pectinate line is removed by a scalpel, damaged by a scalpel. But you can see the relation of it, and you can see